Okay, I think we'll go ahead and get started. So once again, thank you everyone for coming. You're here at the panel discussion to discuss how health information exchanges can bring value during disasters and pandemics. So first up, we'll be talking about an HIE response to a pandemic. And with us today, we have Kim Chandi, who's the Senior Director, HIE and Interoperability at Geisinger Health System and HIE. HIE is a health information exchange in the central part of Pennsylvania. Kim has been part of Geisinger since 2010 after a long tenure at a community hospital in Shamokin, Pennsylvania. She has been involved with HIE since its inception in 2005 and today serves as the Senior Director of HIE, which is one of the oldest and largest operating health information exchanges in Pennsylvania, connecting over 194 healthcare organizations. Joining her today is Martin Chikichop, the Director of Pennsylvania eHealth Partnership Program in the Pennsylvania Department of Human Services. Prior to joining Pennsylvania eHealth, Mr. Chikichop was the Vice President of Research for the Hospital and Health System Association of Pennsylvania, where he worked for more than 30 years helping hospitals and health systems improve the lives of nearly 13 million Pennsylvanians. So with that introduction, I will go ahead and turn it over to Kim and Martin.
Thank you, Drew. It's a pleasure, and I appreciate the opportunity to be able to join this wonderful event. I think Drew was very kind. In the beginning remarks, we were trying to figure out how he was going to introduce us, and he said he was going to keep it funny, so he kept it very sweet. So thank you, Drew. We're actually going to go over a little bit about HIE and how we worked with our state authority, P3N, Martin Chikichop, on how we responded. And
Kim, you got muted somehow.
How's that? Is that better?
That's better.
Okay, so just a little bit about HIE. HIE is, as Drew mentioned, one of the oldest HIEs in Pennsylvania. We were founded in 2005. We're servicing around 7 million patients in both Pennsylvania and New Jersey. Our mission is to make sure we have the ability to share information from providers securely to assure the quality of care for the patient. Our concept has always been the patient is at the center, and we will bring together all the spokes that are necessary to help and aid in taking care of that patient.
You muted again, Kim. I wonder, I'm not sure if you were thought you had slides up, but they are not up right now.
They're not?
No, I'm wondering if that's what's happening. You're hitting the space bar to go to the next slide and it's muting you.
Oh.
I'm doing my tech troubleshooting here over the Zoom.
Okay, is that better?
Oh, there we go, yes.
Awesome, okay. So just for purposes of geographical kind of appearance, this is our catchment area in Pennsylvania and New Jersey. We have denoted all of our participants in Google Maps. If you are interested and want to dive deeper into the map, it is on our website. We also have added the other HIE presence in Pennsylvania. We are one of 5 HIEs in the state of PA. So the silverish gray mark indicates that that is another HIO connection. Something that we strive for in Pennsylvania is to make sure HIOs to HIOs can communicate and send clinical data to one another so that our partners in our facilities really only have to set up or participate with one HIE, but have the luxury and the value add of getting information from all the HIEs. So I'm going to make sure I don't get muted again. Yep, I'm good. Okay. So during the pandemic, few things happened. First and foremost, we had our organizations reaching out to us, knowing that we had the ability to really translate what was happening and what was transpiring over time with our existing information that we were already getting from our organizations. We developed and started with the existing infrastructure to build out what we called a heat map. This heat map was used by organizations to track the progress or the potential exposure or the possible exposures of the patients through Pennsylvania, so that would allow them to be proactive in setting up potential tents or areas of where there would be, larger amount of populated areas. So we performed this analysis every 2 hours with our already existing feeds. And I'm going to keep trying to say that because I think it's important to note that we built on existing infrastructure that was already in play in Pennsylvania. We started to track and develop a heat map to say, in the top you can see red was patients that have been confirmed that they were exposed, and then the yellow indicate the possible exposures. And if you would view this map every 2 hours, believe it or not, you could actually see how it came across the state of PA, which again allowed our providers, our facilities, to utilize this to understand the path of the pandemic, to be proactive in setting up outside tents and such. On the bottom, we started then to say, okay, as we got a little more educated and a little more clinical data, we started to incorporate lab results into it by zip codes. So in the second lower map, you can see we were tracking patients that were tested but were considered not positive, and then the red were indicating positive test results. Again, it gave us the ability to see outbreaks. It gave us the ability to see the path of the pandemic, and it would really allow us to interact and be more proactive. Once we started to display this and show this, and we worked very closely with our state, again, we wanted to get more information. So as they saw it and we developed the heat board or the heat map, they came back to us and said, can you add specific criteria to it so that we can track? One of the criteria was age. So you can see on the upper lab tab, it is lab results by age groups. The red indicating the positive and the blue indicating negative. But we were able to track not only positive and negatives, but by age. And again, this was done every 2 hours. It's refreshed. It's a real-time URL that you could go out to at any time. And you can see how it fluctuates, day over day, week over week, month over month. And then the bottom was a count of our unique patients, again, exposed by the pandemic. A lot of this exposure was, in essence, trying to make sure we could understand, having to articulate or communicate possible exposures that were, out there and passed along. Again, tapping into already existing feeds, then the next request came in to say, can you track where it's coming from county, from organization, so healthcare organization, and then track the number of possible exposure versus confirmed exposures. And these are interactive maps that you could drill in and out of and be able to see exactly how each of those counties or organizations are seeing upticks or decreases, and not just daily, but every 2 hours. We also started to, HIE, as well as our other partners here, our other HIO counterparts, started to send out a, I'll say every 2-day COVID-19 dashboard from our perspective. So we sent this dashboard, and we're still sending it to date every 2 days to the state so that they can have a nice look at what's going on in each geographical area. This information is used at the state level to complement or to assist with their already existing dashboard that they have in play. So you can see this is just a different look. It gives you, the positive encounter diagnosis, it gives you negatives, it gives you the amount of results that were performed. Again, it breaks it down into gender as well as race. Again, I think this is not only used at the state level, but this is also sent to all of our participating organizations, and it is viewed at their executive leadership meeting. Just to add a little bit of additional clarity to the dashboard that we added, we did do some daily trends. We did some unique patients in the lower left-hand quadrant. We actually did this to show you how you can see how it moved over the state, how it progressed the pandemic through the state of PA. And then it really allowed us to alarm or notify, I shouldn't say alarm, notify our, existing counties that, hey, we're starting to see movement or starting to see some activity in your area so that they could be prepared. We also broke it down by, again, race, ethnicity, age, and then the positive COVID counts as a whole. So by far, females are highly more susceptible to it in our findings here in Pennsylvania. One of the also requirements from the pandemic situation for the Department of Health was the need to be able to electronically track bed availability. Our organizations came to us and said, is there any way you can assist and aid in this? Because it was critical for DOH to have a really good understanding of what the bed capabilities are and availabilities per organization, knowing that the pandemic was coming across the entire state. We were able to automate this process for some of our organizations by taking their existing bed census, calibrating which ones they would be utilizing for COVID patients and ventilator patients. And we were able to automate this process and send this to them 3 times a day. Prior to us automating this, there was a person at each of the organizations that individually had to go in and enter this data. We really strive to make sure we can help from an electronic perspective, automating processes to free up manpower hours to really focus on the patient and the direct care, and still make sure that we can facilitate and communicate the necessary information to our state and to others so that they can be aware and be able to prepare. So this was a huge win for us and for the organizations. We also had, and this is basically one of the concepts that we had, is setting stuff up typically usually takes a long time until you're in the middle of a pandemic. Once you're in the middle of the pandemic, it gives you an opportunity to rapid fire. And, we were given permission to test, automate, set up, and communicate one of our organization's labs tests directly to the PA NED system. Typically a connection like this, with not having all body kind of hands on deck and working towards it, can take a couple weeks. Driving this because of the pandemic and the importance of making sure that we were able to get those positive test results to the state in a timely manner. Start to finish, we were able to set up Allegheny Health, which is a pretty large organization in Pennsylvania, within 5 days. We have proven that we can expedite and be cost effective with using already existing infrastructure and be able to turn around requests quicker, faster, and smoother than anything, even in the middle of a pandemic. I'll just want to thank you. I will be here for questions after, but I'm going to turn it over to Martin from the state, and he can take it from the state's profile or the side.
All right. Sure. You're still going to drive the slides, though, right?
Absolutely.
Okay, great. Why don't you go to the next slide? Once again, it's a pleasure to be with you in spirit, I guess, in Montana today, or virtually at least. I'm going to give you a quick background. Kim already touched on some of the ways that we do enable health information exchange across the state of Pennsylvania, but I think we're a little bit unique at this point, where we have 5 different regional health information organizations and various state agencies that are interconnected through a federated infrastructure in the Commonwealth of Pennsylvania. So I'll talk a little bit about that sort of unique setup and some of the other HIOs, which can give you a good overview of what HIE is. But we've got 4 other organizations like HIE, but none of them are exactly the same. And I think understanding a little bit where your journey is in Montana in setting up your HIE and multiple attempts and different efforts across the state, now being able to leverage a statewide health information exchange. You might learn a little bit about the differences of HIEs and bringing them together in Pennsylvania. So if you go to the next slide, Kim. Again, we are the Pennsylvania Health Partnership Program is in the Department of Human Services. We originally started outside of the Department of Human Services, but we found that being part of the agency in Pennsylvania that controls Medicaid and accesses or has purse strings or the ability to access high-tech funding was very important. So we've been able to leverage high-tech funds in Pennsylvania for growing the services that we have across the HIE community, but also growing participation in the HIEs. Tom Novak this morning was talking about having access to onboarding grants. That's at least what we call it in Pennsylvania. But we've onboarded hundreds of facilities over the last 6 years using high-tech funds. But being part of the Department of Human Services has been a key to getting there. We have an advisory board made up of diverse stakeholders, but really the heart and blood of the Pennsylvania Health Partnership Program, even whenever we were an independent authority, is a Health Information Exchange Trust Community Committee. It's chaired by Kim Shondi, but it's made up of the leadership of 5 of the HIOs and our Pennsylvania Department of Corrections. It's really the operations committee. We discuss policies and operational issues month in and month out. And it's really a unique collaboration that we've got between all of these HIOs in Pennsylvania. Next slide. Our vision is simple. Health information exchange ought to make healthcare better. And our goal is to have ubiquitous, robust health information exchange. And by doing that, by getting all providers connected, and we're well on our way to doing that. The white space in Pennsylvania is continuing to shrink, and we are definitely taking advantage of the last year of high-tech funding for closing hospital and nursing home and physician white space in Pennsylvania. Next slide. A simple way to think about the statewide health information exchange is in Pennsylvania, patient presents at a provider. That patient might have been a patient of that provider their whole life, and that provider might have provided all of their care, and in their EHR, they might have everything that they need to be able to effectively care for that patient. But that patient might have received care from other providers. Using the connection to the local HIO, the provider can query their clinical data repository and get lab results or discharge abstracts from other providers in the community. That patient might have also received care somewhere else in the state, or might have received care from a provider a mile away, but that provider is connected to a different HIO. The P3N query generates the clinical data about that patient from all 5 of the HIOs, as well as our Department of Corrections. Once the provider cares for that patient, effectively using the most current, most complete information about that patient, they discharge the patient, their EHR creates a discharge abstract. The discharge abstract is automatically published to the clinical data repository of their HIO, and it's available for query and retrieval by the next provider, either locally or across the P3N. Next slide. So our health information exchange in Pennsylvania works locally within a provider's EHR, regionally within the HIO that they're connected to, and statewide across the Pennsylvania patient and provider network. Next slide. Mentioned earlier that we were established or moved into the Department of Human Services in the summer of 2016. Again, the goal was to be able to leverage Medicaid funding to help support interoperability, health information exchange, and we've done that pretty effectively in Pennsylvania. We have 5 HIOs across the state that are interconnected through the P3N. They go through a certification process. They also all sign a common participation agreement that dictates how information is shared in Pennsylvania, has policies and security requirements that are in it, and based on the technical onboarding and fulfillment of all the requirements of the PAR, they become a certified P3N HIO and can share information across the P3N platform. Again, the Keystone Health Information Exchange is just one of those HIOs. And the Department of Corrections in Pennsylvania has 25 different state correctional facilities that are interconnected. Their EHR is interconnected to the P3N to be able to query and retrieve documents on their patients, as well as to provide information whenever those patients are discharged to the community. Next slide. So really, we're set up as a federated model in Pennsylvania. So the P3N infrastructure supports that federated model by having a master patient index at the state level, a record locator service, a provider directory. Pennsylvania, like Montana, is an opt-out state. If a patient or a citizen wants to not have their information shared across the P3N, we honor that request and have the ability to block that information from being shared. If a provider queries for information about a patient who opted out of the P3N, instead of getting back a clinical payload, they're going to get back the signed opt-out form. Now, a patient can opt back in, but that's how opt-out works in Pennsylvania. And counter notification service, we'll talk about that in another slide or two, because that really provided the value to the state of Pennsylvania for some early information on COVID diagnoses across the state. Also have an advanced care plan registry that's available. And then in the middle of this slide, we have the ability for providers who are connected to our HIOs to fulfill their public health reporting requirements by having just that connection to the HIO. So we have providers who send immunization information system automatically through their EHR, through their HIE, through the public health gateway to the state registry, and they get back the immunization records for patients in the same automated fashion right through their HIO. Similarly, we do that with the cancer registry, with the prescription drug monitoring program, electronic clinical quality measures, and so on. Next slide. It's kind of a messy spider diagram, but this is a depiction of the public health gateway, and a recognition that all of our 5 HIOs have providers who are in production with one or more of the public health registries, the electronic clinical quality measures, cancer registry, immunization information, lab reporting. I'll talk a little bit more about that. We've got syndromic surveillance available, but not a connection. The PDMP, and we're soon going to be adding electronic case reporting to our public health gateway. Next slide. So we talked a little bit earlier about the query and retrieve model and how information is shared across the P3N. The P3N encounter notification service is a push model. I think Tom Novak this morning was talking about, the value of an HIE really whenever you can provide alerting, and it's something that you can't do through Commonwealth or through your EHR vendor. But what each of the HIOs have done is they've enabled within their membership the ability to provide alerts whenever patients are receiving care. They can alert the patient's care team or care coordinators within their payer members. And many of our HIOs have payer members, part of the sustainability model, but it's also a requirement in Pennsylvania that all of the Medicaid managed care organizations have to be connected to one of the P3N HIOs. The way the encounter notification service works is we are able to notify a patient's care team whenever a patient's receiving care outside of their HIO. At this point, we've delivered more than 20 million messages in the last 2 years across the service. There's 107 emergency departments that are sending us real-time ADT messages. Just over 30 inpatient facilities are sending us real-time messages. An emphasis for us right now is to get all of the inpatient providers connected to all of our HIOs to send ADT messages. That's particularly important from a Medicaid perspective. For our Medicaid MCOs, they really need to know real time when their patients are being discharged or admitted to emergency departments or hospitals, that they can perform appropriately in providing for care coordination for those patients. So we hope to be able to be over 110 EDs and inpatient facilities sending ADT messages in the next couple of months. We're also going to start collecting and sharing ambulatory ADT messages. Next slide. So what happened with COVID-19 in Pennsylvania? COVID-19 in Pennsylvania really started to ramp up in early March, much like it did across the country. But what we did is started to facilitate weekly meetings of all of the HIOs, and we brought in representatives from the Department of Health whenever needed to be able to help with collaboration. One, to understand from HIO to HIO what they were seeing in their community, how they were responding to that. The dashboard that Kim showed you all some screenshots of earlier is also a dashboard that one of the other HIOs is using a very similar kind of approach. And again, in coordinating a response to the Department of Health, we encourage the HIOs to one, be responsive to questions and ways that we could help from an individual HIO level, the Department of Health, and getting their arms around COVID-19. We also got an agreement among all of the HIOs that we could use information that is being sent to us for the ADT service to produce daily reports for the Department of Health based on exposure to COVID-19 that we find in the diagnosis codes and ADT messages, or confirmed cases. And we also offer the Department of Health, the ability to have a portal access to the P3N, and we offered them, the ability to actually get the ADT messages. They opted to get the daily reports, and they've also asked for additional information in terms of demographic information, because I think one of your earlier presentations, folks mentioned that the data that the Department of Health gets from COVID tests is incomplete. It doesn't provide good sex and race information. So we're able to provide that as a resource for the Department of Health. As Kim mentioned, onboarding Allegheny Health Network in 5 days to our electronic lab registry through the Public Health Gateway was quite a feat. But we had a lot of momentum within our PAs, or in our electronic lab registry within the Department of Health, to get all of these test results in a very effective way. So we went from having about a dozen ELR connections through the Public Health Gateway, about 4 dozen ELR connections in a matter of a couple of months. So now there's more than 40 hospital labs that are reporting their COVID-19 results to the Department of Health through their HIO, through the Public Health Gateway, in an automated fashion right into the electronic lab registry. Now, we had asked and are still awaiting a response for the Department of Health to make COVID-19 test results that they receive available to the HIO community. And we're hopeful at some point in the future we'll be able to deliver that through the Public Health Gateway. Next slide. I mentioned that our surveillance of ADT, the admission discharge transfer messages that we use for our encounter notification service, we're using and providing daily reports to the Department of Health. And this graphic shows the progression, or the daily cases that we're reporting, in this case, exposed cases for COVID-19 in Pennsylvania, for just the messages that are flowing across our ADT service. Next slide. The number of persons that we're reporting confirmed cases for is on this slide, and it shows that we're in a second wave. Maybe even, we had a little wave in the middle, but we're now in a wave for COVID cases that was higher than the initial wave. Fortunately, we've got better ways of handling patients who are COVID-19 positive, but this information, we're able to share diagnoses, we're able to share patient demographic information directly with the Department of Health. And while this isn't showing a huge number of cases in terms of daily cases, and certainly not the universe, this trend almost identically mirrors the next slide, which is the confirmed cases that are on the Department of Health's dashboard in Pennsylvania. Again, the trend is almost a direct mirror of the cases that we're reporting to the Department of Health. I think that's the last slide, and I'll stay around for questions as well.
Yeah, thank you, Martin and Kim. It looks like it's gotten dark here. I've lost my light, so I apologize for the video. Thank you both for sharing some of the challenges and solutions that you were able to present during this pandemic. So thank you both for that. Okay, Kim, if you want to stop sharing slides, and then the next set of speakers we have are going to talk a little bit about how an HIE was able to help with a response to a natural disaster. So with us today, we have Phil Beckett, and Phil Beckett is the CEO of HIE, which is Healthcare Access San Antonio. And Phil joined HIE in September 2015 as CIO to deliver HIE services in the Dallas, Fort Worth, North Texas, and West Texas areas. Phil served for the previous 3 years as the Chief Technology Officer and Privacy and Security Officer with Greater Houston Health Connect. And Phil has been instrumental in continuing to expand the services that are offered through the HIE through collaboration with community partners. Also with us today, we have Jim Hogue, who's the COO of HIE. And Jim has over 15 years in healthcare administration around physician practice operations, medical education, outpatient departments, and behavioral health. Jim is excited that HIE's passion is to create a connected community of providers for patients because, as he says, the right care at the right time requires the best information possible. So after those introductions, I will, Phil and Jim, turn it over to you.
Get myself off mute. Thank you, Drew. Thanks for the introduction, and it was much kinder than I thought you were going to, as you and I have known each other for years.
Boy, I'll tell you, I've disappointed everyone today. Kim was disappointed. Now you're disappointed. I sincerely apologize, everyone. I'll do better next time. All right.
No worries at all. No, thank you. And we did actually, just for the record, we did drop the Healthcare Access San Antonio since we're cover a lot more region of Texas now. So we've just taken our acronym as HIE and run with it.
Gotcha. Yeah, I tried to research that on the website. I still found a reference to it. So I guess you have to update your FAQs, Phil.
Yeah, I guess so. You dug deep.
I went deep. I went deep.
Well, I thought my friends in Montana would enjoy this. You know, Texas started in 1836. As we took it back from Mexico. Some days it still feels like we're here, but I love this. You know, I still live in. My house is in Houston. I still live there. This was just after the 1830s, and the Allen brothers from New York City came down and in a steamboat and got up the bayou to where Houston is now, and sort of marketed this as beautifully elevated area surrounded by towering hills. If any of you have been to Houston, the towering hills, enjoys the sea breeze and all its freshness, and is, quote, well watered, which we're going to talk about hurricanes here. So the first big one was in 1900 in Galveston. This really helped. Galveston was the main city there in Texas at the time on the coast. After this, the hurricane, it really was the promotion of Houston, about 50 miles further inland, where it was a little more protected from this. But this basically caught everybody by surprise. We didn't have weather forecasting. We didn't have forecasting systems. We didn't have communication, interoperability in the way that we do today. And a lot of people didn't know to evacuate or didn't know this thing was coming, and took it hard. The place got shattered, and several thousand people lost their lives because they took bodies down the street in horse and buggy here, threw them in the ocean. 3 days later, they all washed up back on the beach and made an unpleasant smell. So this was the track of that 1900 hurricane, again, which didn't have a name, didn't have names at that point. But you see common pattern. After that, Galveston, which they built a seawall over here to really protect and raise the whole island about 19 feet, basically, and rebuilt everything. Dug a big hole in the process on the backside as well, but then put this up and to help protect themselves, at least physically. And that was really Houston gone. But this is a map, you know, for since 1851 to 2005, 2004, sorry, 13,000 storms, and you can see they pretty much cover. And here we are on the Gulf Coast here, where Texas is pretty much frequently getting hit. You know, from this year, we've had 4 hurricanes hit this same section of coast over and over again. So they're a common feature of where we live, of coastal Texas. Since I've lived there, again, some of this is personal. Allison, I remember it was not really a windy event, but it was a flooding event in the medical center where I was working there. It had a lot of generators in basements. All got flooded. The water, it's a flat place, no matter what the Allen brothers said. And we got 20 inches of rain in 6 hours, and it just filled up like a bathtub and flooded the hospital systems. They lost their power. They lost their generators. They lost their data centers, and it was a mess. About $2 billion worth of damage just right in that place. And I remember walking down our street about waist deep in water. It was quite impressive. That was my first experience. Katrina was 2005. Rita were also in Katrina, of course, was New Orleans. You all remember that story. Rita was 2005 as well. It was mild for the hurricane, but after the Katrina experience, where everybody watched what happened in New Orleans, and there was an incentive to evacuate, we evacuated too. The hurricane never really came into Houston, but what ended up was millions of us on the road stuck in a big old traffic jam and couldn't go anywhere, and about 59 deaths on the road. So more people died on the road evacuating than would have been, which probably would have been zero from the hurricane. Then a few years later, Ike hit, direct hit against Galveston and Houston. This time nobody evacuates because that wasn't any fun. But the hurricane really did hit. That was, again, ugly experience. About 19 billion in damages, 84 deaths. And then the one we're gonna talk about, Jim and I are gonna talk about a little bit more, was Harvey in 2017. This was the one that sort of circled around and never left and flooded the place. But this is what the evacuation looked like. You can imagine being stuck here, 5 miles from your house, and the hurricane's still coming at you. You can't go anywhere. These were some photos these are my own photographs from our own house here, from a bridge on the road looking towards downtown Houston. You see this is I-10, the freeway, just full of water. These are a few houses in my neighborhood where we live. Again, this is not just, doesn't happen once, this happens pretty frequently. So what happened in Harvey, where we set up the cities set up mega shelters. And again, I think this is interesting to tie back now, obviously with COVID, nobody wants to be in a shelter with 14,000 people. So that's interesting dialogue, and I hope we can have some questions around that. How do you manage that? But there were shelters in Houston, San Antonio, Austin, and Dallas. And I'm going to ask Jim to talk about, because he was personally involved in the Dallas shelter. But I just briefly as well, just to share something about the HIE coverage across Texas before I hand over to Jim. We're like Pennsylvania, we're a decentralized approach. Several health information either covering different geographic areas or overlapping, and a state level platform in the middle of HIE Texas designed to connect us all. Ironically, in the middle of Harvey, just because of funding, nothing to do with Harvey, but it was right at that time, the HIE Texas connections were decommissioned, and it made a little extra challenging. This is kind of a picture of Texas. The red is HASA, that's us. That's why we dropped the San Antonio part, because we're all over the place. This is where Jim is today up here, and he's been driving all over this part. Houston has an HIE that I was part of before, Greater Houston Health Connect, covering this region. There's one in the Valley, Rio Grande Valley, and in El Paso we have one, and one in Austin around the capital. And then this, Jim, I would like to hand over you, please. You've got a lot of sort of experiences and personal experiences there of what we did during when thousands of people evacuated are now in shelters, and doctors are trying to give medical care to people that they don't know.
Yeah, thanks, Phil. And in fact, you know, I was thinking back about that today, thinking about my time in the shelter. You know, one of the things that had happened, as we discussed earlier, Drew mentioned the idea of the start and stops and HIEs around the state, and Phil mentioned about at the state level, but you know, Phil had come over to HASA from GHH out of a desire to really grow the HIEs. The North Texas HIE had actually, it had been started around the time of all the HIEs and had gone under about 2 years before. And several of the health systems there put a lot of money into starting that up. So, you know, as Phil and I were brought on to help, you know, build and grow the HASA community statewide, and there was a little bit of resistance in the Dallas area. So one of the things that had occurred when this happened, you know, we were talking with the health systems and the county health about what was going to happen about Harvey. And at first they were a little reluctant. You know, their history was, you know, letting in someone that's part of a failed effort. And so, you know, but we spent time with them and talked through what we would be able to do. And they weren't really interested in setting up their own HIE. So, you know, we committed just to be there during the shelter operations when they had a shelter clinic. And so when they opened up the clinic, we were there, and I was there for 19 of the 21 days that shelter clinic was open. I'll tell you, one of the learning experiences I have is I didn't have gloves. I didn't keep my laptop clean. And had I been trained, you know, as a nurse and used to walking around with a laptop, I think the hygiene would have been better, because I had 2 stomach viruses that I just had to deal with over those 3 weeks. But the Dallas Mega Shelter was really amazing. It was the Dallas County Convention Center, and what they did was they opened up the entire parking garage. Level 1 was where they put all of the beds. That's where entry and exits were for security. And on the far end was where we set up the clinic. And the clinic were just tarp walls that separated all of that bed area. And we had the state guard that created separation so that the clinic could be run well. And we had the Dallas County Medical Society coordinated all of the volunteer physicians and nurses, and the county health, so Parkland Hospital, UT Southwestern Medical, coordinated the medical command team along with Dallas Fire and Rescue. And then the County Medical Society basically filled in all of the volunteer clinicians to make this thing run. And, you know, the shelter did have 4,000, but Dallas, they also opened up another 3,000 to 4,000 in the area hotels. So what ended up happening is, while the shelter had about 4,000 people sleeping there, there were between 5,000 and 6,000 patients that came through the mega shelter clinic. So it was amazing. Some of the best people. The medical director, who is faculty at UT Southwestern, was there for a different 19 days, but he also was there 19 out of the 21 days, working 12-hour shifts. And it was an amazing response to this. And it was a great team. And by the end, you know, they really had incorporated the HIE into the medical command. We were able, by the end, to be able to describe what we're having difficulty finding, what we're able to find, to try to tap these folks, so that about halfway through, the part of the check-in was bringing patients through the HIE, because we sat up right behind the registration desk. They brought patients to me. we basically set up login to the Greater Houston Health Connect, and basically I began doing patient lookups on every patient that came through. And some of them are critical, and I'll talk a little bit about what we had to do otherwise, but some of what we ended up having to do is just Googling clinics and hospitals, especially over east of Beaumont and Orange County, where things were decimated, and phone calling, looking for things. So you can see some of the things that we were trying to do on a daily basis, the collaboration that took in. I won't belabor that slide, but you can see all the things that we were doing to try to manage. There were things, dialysis that needed to get taken care of, patients that need to get moved from the clinic over to hospitals and back. And it was a huge command team that were required to manage what to do with patients with medical needs. Next slide, Phil. Some of the things that come up, as Phil mentioned, because the HIEs were not tied together, and the Dallas-Fort Worth, the North Texas HIE had gone under, Texas Health Resources was the only health system in the metropolitan area that was connected to an HIE, but it was the other systems, the county health, Parkland Hospital, and the medical center that were officially part of the shelter clinic. What that meant is that we weren't connected to be able to feed them HIE data, which is what it required, having one of the HASA team there for 10 to 12 hours a day while clinic was running. And there were some stories that you understand why in the middle of a crazy situation where patients, thousands of people displaced, hundreds of miles, that all of a sudden things began to take shape for the need for HIE. So we had a couple things I can tell you about. We had this lady come in, that 61-year-old female, and she had had a hip surgery recently, and she wasn't feeling well. She also didn't have very good recall. And so they had brought her in, and we couldn't find her at first. As we were searching, we had to look up different names, and she had gone back, and turns out she had had a fever, she was in pain, and she had had recent surgery. So what was first two steps? One would have been pain control, and the other antibiotics in case the fever was related to any sort of infection. And we kept searching and finally found her in the GHH portal. And come to find out, she had a med allergy for both hydrocodone and amoxicillin and penicillin. So, those are both first line in a situation like this when you talk about free pain meds and free antibiotics that the pharmacies were providing. And I printed it off and got it back there before they were able to fill at the pharmacy. But they likely would have treated her in two situations with two medications that would have interacted for two medication allergies. We also had this little kiddo there that we dealt with for several days. It was a 10-year-old, and he had mental health issues. He had several behavioral health diagnoses, and he came up to Dallas with his mother, but it was his father who was the primary caregiver. So the mother did not know which doctors that he was going to and had no medication list. And over the course of a couple of days, he was becoming more and more aggressive. And this was one that it took us, with her not knowing any of that, we got some information from the HIE. And then I used it to actually call down back to, he was actually from Houston. And I got a partial meds list from one of the clinics down there who said that they had some history for another physician practice. And that was a mix where because some of the docs weren't connected to the HIE, but because we were able to do that, we were eventually able to get his full meds list so that the psychiatrist, the behavioral health group at the clinic could figure out exactly what the diagnoses were, what the meds were, but also the dosages with the little 10-year-old. And then on the next slide, Phil, is a story of a patient who came and presented. She said that she had cancer and needed medications for treatment with it. And one of the things, so we looked in the HIE and her provider was there, but there was no cancer diagnosis. So we went ahead and called them, and they said that she was actually on a pain management contract and was drug seeking. So it was one of the situations that because we had access to her history to see her provider and showed no cancer diagnosis, that we were able to figure out that in a situation like this, they would have treated her in the middle of a disaster on face value. And you know, there were definitely several. Phil, you had a couple stories, didn't you?
Yeah, there's lots of. Although I just want to do a time check with Drew, because we're going to leave time for questions as well. How are we doing, Drew?
Yeah, I believe we're doing all right yet. No one's been letting me know. So we're done at 15 after. So I'd say we have another 5 minutes or so, if that would be okay.
Yeah, sure. Or maybe I can just close out with, this story again. Just sort of the personal stories make it really impressive. The ones that Jim's sharing there. This was one that I was in the Houston shelter at the same time, and the George R. Brown Center there. And this was a kid, and I was in the clinic as well in the same way. Or this, you call it clinic, but this area of physicians and tables. This kid comes up to me and he says he has asthma, but he doesn't remember what he's allergic to, and is worried that something in the shelter is going to set him off, and he wants to know what that is. But it also, he's despite, in this, as the water comes up in Houston, people just scatter, and he's got displaced from his family. So this kid's in this shelter with thousands of people and no family. And so the greatest thing for that was I found his mom's phone number in the health information exchange, and I called her from my own cell phone, and she was able to tell me what his allergies were, and I could write those down and give them to the kid. So he had those, but also, just to be able to reunite the two of them, that was so powerful. So I think some of the simple things that we can do, and this is a few years ago now. We've been fortunate that we haven't been hit again in Texas so badly as this recently. It's going to happen. It's just a matter of time. So we're trying to drive our infrastructure to be better, and we're implementing the Pulse system. It's been used in California in wildfires, but putting that in place in Texas, and put connectivity away, joining national networks like Care Quality and Commonwealth, eHealth Exchange, so that I hope, although Jim and I will probably still be in shelters, but that we can automate a lot more of this in the future and be able to respond to disasters with first responders in a much more coordinated and frictionless way. And I think with that, we'll hand it back to you, Drew.
Yeah, thank you, everyone. I appreciate you guys being able to share that story of how the HIE was able to help you guys during your response. That was very informative. All right, so I think we will now go to our question and answer period. So let me see which ones we have. So I believe there was a question that was back to Martin and Kim, and I believe, Phil, you asked this one. So for the electronic lab reporting to the state, did you need to ensure correct coding of results and orders with a standard such as SNOMED or LOINC? If so, how did you achieve this? If not, did Department of Health manage the data to compare apples to apples?
Yeah, so I can take that, and then Martin, if you want to add to it. So the state was working closely with us to identify specific link codes as well as SNOMED and ICD-9 codes that they wanted us to pick up either from a lab test or from within a CCD. So we were being driven from the recommendation from the Department of Health.
Part of the reason that the onboarding to the lab registry often takes longer than a week is getting those standards squared away between the provider organization and the Department of Health. They won't accept any reports that don't have the standard codes. There's a lot of back and forth testing to verify that.
All right. Thank you both. Hopefully it answers the question. If not, feel free to follow up in the chat or the Q&A. Okay, this question looks like it was directed to Jim. Jim, do you know what they were using for an EMR at the shelter that you were able to use to connect to the data back to the HIE?
So in fact, they were on paper, and I was there with the laptop. So they would bring me the paper demographics, and I would look them up. I will tell you some of the follow-up meetings that we did for the Dallas County response to disaster is that likely they would contract from the beginning to have the county hospital, Parkland Hospital System, use their devices and their EHR, and they would contract and extend the county hospital system out. Because what they ended up with was 6,000 paper records that honestly is still being stored in the Dallas County Medical Society basement. They don't know what to do with it. It's all paper. There's a lot of good data, but none of them at the time were members of the HIE to be able to give that data to us. We walked through that, but there's just a lot of data sitting on paper in the basement.
Yeah, thank you. I just also wanted to mention you some wounds that had closed years ago from the North Texas Accountable Healthcare Partnership came back open again when you mentioned that. Seems like another lifetime. Yeah. All right, thank you for that. Next question was for all the panelists. Are any schools involved in your respective HIEs? And if so, how has the HIE assisted with the school's COVID effort to keep students and teachers healthy and safe?
This is Phil. Well, we do not have any schools connected into the HIE.
Yeah, and this is Kim. We don't have schools connected, but we did assist with our local schools in assisting with sending notifications and informational things out to them, when it started, and reminders and such from a marketing perspective. But really hopeful and wanting to get into that school setting, because I believe that can really assist even without a pandemic for the nurse to be able to have access to students' health issues.
Yeah, thank you. Martin, anything to add there?
Well, across the HIOs in Pennsylvania, schools have not been a member demographic or member group for any of our HIOs, not for lack of interest. I mean, we would like to be able to provide access for school nurses. There is access to the PASYS, the State Immunization Information System, for the school nurses, but that's just a small piece of what the value that they could get from being part of an HIE.
All right, thank you. Next one looks like it's for Kim and Martin. So how are social determinants of health integrated into the Pennsylvania eHealth connections and HIE, and how did you help with your state's, and how did it help with your state's COVID response?
Martin, I'll let you take that one first.
Sure. So social determinants of health is some of the diagnoses are standardized, and we can pick them up and share them, through continuity of care documents or CCDAs. But generally, the organizations in the community that would deal with the social aspects of social determinants of health are not generally the members of the HIEs. But we're breaking that down in two ways. One is area agencies on aging. In Pennsylvania, we have 67 counties, 53 different health or area agencies on aging. Organizations contract with our state Department of Aging, and they provide huge amount of services and care coordination and assessments for the aging population in an aging state, which Pennsylvania is. And we now have about 1/5 of those area agencies on aging are members of our HIOs. And in fact, the state Department of Aging is doing a full court press to get all of the area agencies on aging connected to HIOs. And maybe Kim can talk a little bit, whenever we're done, about the value that those area agencies on aging get from having now multiple years of experience with being part of the Keystone Health Information Exchange. But in Pennsylvania, we're also working on creating a statewide resource and referral tool that is focused on the grassroots of all of the community organizations that help to support the citizens in Pennsylvania who have social determinants of health needs, whether it be food insecurity, housing insecurity, safety. All of those organizations and area agencies on aging would fit into that, are going to be interconnected in Pennsylvania through something called a resource and referral tool. And while it's not being built into the statewide health information exchange, at the state level, it's going to be interconnected through our state Medicaid management information system. So the P3N is going to be integrated into the MMIS, and the resource and referral tool is going to be integrated into the MMIS, creating that linkage between the health care providers and the social care providers that is really needed. Kim, if you could talk a little bit about the experience of area agencies on aging. We also have some
Sure.
food providers who are already connected to HIEs.
Yeah, so the ENS service that we referred to earlier, the electronic notification service, is something that is used heavily with that patient population. So we're able to identify a case manager or a social worker's load and track where their patients are being seen. We did a use case study that we're actually saving at least 2.5 hours per week for one of those individuals because of just setting up notifications. So instead of someone driving out to the home to see the patient because it's a scheduled event and to find that they're not responding, they're not there, or if they're not there, then they have to get the enforcement involved to see if they have to break down doors to make sure they're okay. With the notification service now, we're notifying them proactively, hey, this patient just went and was admitted to an ED setting. So it really has cut down on that, I'll say, potential unnecessary alarms going off, but it also allows them to save some money because a lot of these patients are set up for Meals on Wheels. So the meals go and they arrive and nobody's there and they have to throw the meal away. Or it was, oh, I was notified, now I got to track down the Meals on Wheels to stop it and not have that processed to that patient for that day. And believe it or not, there was a large dollar figure savings just for the amount of time spent notifying and understanding where the patient is, and be able to build use cases and trigger points around what they need to do to understand where and what's going on with that patient.
Yeah, thanks, Kim and Martin. I think that was a good answer. Let's see. So there was goes back to the floods. Maybe just some clarification. So Jim, you said at the time you were just using paper, right? There was no particular EMR that was being used at the time, right?
Yeah, that's right. I went into the HIE portal and typed it in, and it was based off just paper charts. They're likely going to have the county hospital, use it next time. And we've been growing that, the market there. There are a few Epic shops that are able to communicate most of what they need with each other. But we've got a couple of health systems connected in Dallas-Fort Worth now, and talking to a third. And so it is getting more connected there. Some with us, some within the Epic shops.
Yeah, thanks, Jim. Appreciate that.
Yeah.
I think those were the questions that we had so far that were answered. Still some time left if folks have additional questions, or Stephanie, let me know if I missed any. And once again, I do want to take the time to thank all of our panelists today who came to participate. Luckily, they were nice to me as well, because a couple of them here have had the pleasure of working together. So it's been good to see some familiar faces again.
Definitely, Drew. Thanks for having us.
Yeah, thank you very much.
Thank you for having us. And as always, if there's any questions or afterwards, please don't ever hesitate to contact us. More than happy to, talk about our experience, and hopefully maybe we'll have an opportunity to learn from your experience as well.
All right, yeah, oh, sorry, did I step over somebody?
I'm just going to encourage you all to sign up for the Big Sky Care Connect. The value in HIE really is driven by the participants. The more participants you have, the better the ability to have information shared and information available at the point of care.
Yeah, I think that's an absolute key takeaway, Martin. Thank you. Appreciate that. Okay, well, if no further questions, I appreciate once again everybody's attendance and all of our panelists again today. So we will have looks like closing remarks coming up at 4:15 to 4:30, and then we also have a question and answer session that if you do have some additional questions that have come up that you'd like to ask, that begins at 4:30 Mountain Time. So thanks again to everyone, and enjoy the rest of your day.